Ladies and gentlemen, welcome to the Changing the Culture, Improving Recognition and Management of Sepsis webinar. Your hostess for today is Lauren Smith. Lauren, the floor is yours.
Thank you. Hello, everyone. This is Lauren Smith with MPRO, one of the organizations that is part of the Lake Superior Quinn Quality Innovation Network, or Lake Superior Quinn. Lake Superior Quinn represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. We are all working with organizations in our states in a community-based approach to reduce the 30-day hospital readmission rate by bringing organizations together to improve care transitions. This webinar series, Success Stories, highlights the innovative work the Lake Superior Quinn Coordination of Care Initiative partners have done to improve transitions of care and reduce readmissions. This is webinar 5 of the series of 6. I would like to welcome you to this educational session entitled Changing the Culture, Improving Recognition and Management of Sepsis. Because Medistar is providing continuing education credit for this presentation, we need to inform you no commercial support has been received for this learning activity. The speakers and planners have no conflicts of interest. For CE credit or a certificate of attendance, you must attend the entire session and complete an online evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. An email evaluation link will be available at the conclusion of the webinar, and they also send the evaluation link via email. Participants in a group setting should submit a list of who participated with email addresses included to continuing-ed@medistar.com. Please note that all lines are muted during this webinar. However, after the presentation, we will have a time for questions and answers. So please make a note of any questions that may come up, or you can use the chat feature on the right side of your screen. Now let's introduce you to today's speakers. First, we have Pat Hoza, the Population Health Clinical Integration Leader for St. Joseph Mercy Health System in Southeastern Michigan. She has been involved in many quality and patient safety programs, such as hospital and crisis management programs and a statewide Keystone ICU patient safety initiative. Pat has been faculty for multiple state and national clinical collaboratives, including the Surviving Sepsis Campaign, Phase 4 Collaborative, and the National Project on Comprehensive Unit Safety Program, or CUS, for mechanically ventilated patients. Through Pat's leadership, St. Joseph Mercy Hospital was awarded the HHS Critical Care Society Outstanding Leadership in Eliminating Central Line Associated Bloodstream Infections and Ventilator-Associated Pneumonia in 2011. She was inducted as a fellow into the American Academy of Nursing in 2013. In 2017, Pat was awarded the Michigan Hospital Association Quality and Patient Safety Leadership Award. Our second speaker is Rob Barron, the Director of Care Coordination at Henry Ford Health System in Southeast Michigan. He began working at Henry Ford in 2006 as a bedside medical intensive care unit nurse and advanced to his current position, Director of Care Coordination in the Department of Population Health early this year. His focus is on reducing readmissions and improving care transitions for all patients. He directly oversees the Patient Education Department, the care program supporting family caregivers, and components of the Integrated Case Management Project, which is redesigning its case management across Henry Ford. With his focus on care transitions, he has worked closely with post-acute care providers through both local and regional collaboratives since 2015. These collaborative relationships have led to the implementation of numerous improvement projects, two of which will be discussed today. Without further ado, I will turn it over to you, Pat.
Well, thank you so much, Lauren. And we're going to talk today, just as a quick overview. We'll focus on why sepsis, why now. We also will talk about that we've moved from hospital-centric care, early identification and care of the sepsis patient to post-hospital. And so we'll talk about the collaborative approach to improving sepsis care at skilled nursing facilities, and also introduce that this is also being done with home care agencies, and it's put into a toolkit. And then Rob is going to talk about the ED to SNF checklist, one of the improvement initiatives that has been done in southeastern Michigan with his leadership. So why sepsis? So if you have not been to this website, sepsis.org, I would encourage you to go there and watch some of the YouTube videos on the faces of sepsis as a way to understand why we do this work and why it's important to recognize sepsis early and so that we can save lives. It's one of the key components to education on sepsis at facilities, both in the skilled nursing facilities as well as in the hospital, to ensure that the frontline staff that are caring for these patients understand how important it is to early recognize and treat this population. Sepsis hits close to home for me. This is a picture of my family, my 4 kids and my mother-in-law and my husband. And in that group picture, there have been 3 episodes of, well, actually 5 episodes of sepsis. 3 people have been affected. My mother-in-law, who is in the front, this was her 90th birthday celebration. She had had 2 bouts of pneumonia. The first one, she was in septic shock. The second one, severe sepsis. My husband had 2 bouts of endocarditis, and then the young baby that's second on the right had sepsis when he was born and was hospitalized. So sepsis, and you can see at the bottom right, is one of my granddaughters helping my husband give his antibiotics IV at home, and as he needed it for 6 weeks. So sepsis does come close to home. It affects a lot of people, and by identifying and when you're educating staff, it's important to emphasize this why. It is personal. These are people's lives that we're trying to save, and it's a significant impact. So it affects 1 million people a year, third leading cause of death in the United States, costs a lot of money. And even though sepsis only occurs in about 10% of the U.S. hospitalized patients, it's responsible for more than half of all hospital deaths. So it's a major killer. It also bubbled up to the #1 reason for readmission. What is important is every 2 minutes, someone less dies of sepsis. So this is an epidemic. There's lots of great resources also on the CDC website. They did a study that was published back in 2016 that identified 7 out of 10 patients with sepsis had recently used healthcare services or had a chronic diagnosis that was requiring frequent care, and identified that 80% of the sepsis begins outside the hospital. And so in the work we're going to share today, it's about understanding that most of the sepsis starts outside of the hospital, and so we have to move our early recognition and management program beyond the hospital walls. There's also a great infographic on signs and symptoms of sepsis that you can use for education for the family. So every year, Sepsis Alliance, which is the website I referred you to, sepsis.org, is a nonprofit that was started by a gentleman who, a dentist, who lost his daughter to sepsis after a simple medical procedure of a hemorrhoidectomy. Got infected, started feeling bad on a Friday, and by the time she got in, she went, they said she had the flu, and then by the time she did go in, she was in septic shock and did not make it. So his mission in life is to raise sepsis awareness. So this group, Sepsis Alliance, annually looks and does a survey nationally, and they have begun to see a significant increase in people recognizing what sepsis is. So from 2016 to 17, they saw an increase to 58%. So that means 7 million more adults are aware of sepsis. And those under 45 significantly are more likely to have heard the term sepsis. But 39% of Americans believe sepsis is contagious. 1/4 believe it only happens in the hospital. More people knew about Ebola than heard of sepsis. Nearly 3/4 of Americans say they can identify the symptoms of stroke, but less than 1% can identify the symptoms of sepsis. So we have a lot of work to do to increase public awareness. We know sepsis is a disease that will increase its frequency in our elderly, and you can see, as depicted in this chart, it doesn't just hit males or females. It hits us both, and the patients over 85 are at the highest risk of getting sepsis. It's one of the most common causes of hospitalization for patients over the age of 85, and that's where my mother-in-law fit in the story I shared. And pneumonia, UTI, and septicemia are the 3 major causes for hospitalization. This study shows the significant impact sepsis has on mortality. 1 out of 2 to 3 deaths are related to sepsis, and it's typically present on admission sepsis. And in hospitals, the patients that come in and don't have the low blood pressure, that is often a late sign in sepsis, but without that, they're more likely to die because we don't recognize it. And so you have to have clear processes in place to recognize it early. Sepsis is associated with frequent readmissions, and so this is an older slide, but it's consistent that the sepsis is a frequent reason for readmission, as well as patients who are admitted with sepsis are often readmitted with sepsis or another infection. Sepsis is now the primary reason, surpassing heart failure, for readmission in the United States. And in the state of Michigan, it's true as well. It's the major cause for readmission to any hospital. We also know patients that have been admitted for sepsis or severe sepsis or septic shock often do not get discharged to home. So there's a larger proportion of patients that will get discharged to a short-term or longer-term care, and that's where caring for those patients in subacute or long-term care is important to be on the watch for sepsis. So what have hospitals done to improve overall sepsis care? And that's occurred as far back as 2001 to 2004, when the pivotal studies on managing sepsis were published, and guidelines were developed in 2004. So hospitals have very comprehensive infection prevention programs to try and prevent hospital-acquired infections. And if you don't have an infection, you can't go to sepsis, progress to sepsis. Screening for early recognition, every patient, every shift. So routine screening. Protocols to, if a patient screens positive for severe sepsis, to intervene early, placing the patients in certain levels of care within the hospital, standardizing ICU care, and then hospitals have begun to expand sepsis care beyond hospital walls with our EMS providers screening for sepsis and beginning treatment, and then, as we'll talk about today, skilled nursing facilities and home care. So what can you do as a post-hospital provider? Well, you too can recognize sepsis early and begin to treat. And so that's what we have done in southeastern Michigan. We started in facilities working collaboratively and in partnership with a number of facilities that St. Joseph Mercy in Ann Arbor and another hospital in Livingston and Chelsea sent our patients to, we brought them all together and began problem solving and trying to work on a smooth transition from hospital to skilled nursing facility. And so we identified those top 10 facilities. We identified as a group that sepsis was a priority disease to focus on at our hospital. We were tracking our present on admission septic shock and what the incidence was and the mortality rate, and we were trying to figure out how do we improve that. The patients were coming in so sick, often we could not save them. We began to look to see where they were coming from, and is there a way we can try and catch them earlier. And a number of them were coming from subacute facilities, skilled nursing facilities. And so that was the incidence to begin to partner with those facilities to be able to help with recognizing sepsis earlier. And so we sent out a call to participate to these facilities, and where it outlined what it would entail if you were involved in this collaborative. So it was a 5-month collaborative with a face-to-face meeting each month, and I'll talk a little bit more in detail. So each of the facilities, the administrator of the facility needed to sign on and say, yes, they were committed. These are the expectations of the facility. This is the benefit of the program, and then return it that signed so that there would be support for their staff to attend and participate. So we originally did bi-monthly meetings, and then as we've continued to expand this program and offer it to other facilities so we could run the program twice in a year for different facilities, we moved it to monthly. So it would follow, we would have a local meeting with our extended care facility partners, and so when we first started, we had this meeting follow that, so they were there. We walked through an action plan, and I'll show you that action plan to implement a sepsis early identification and management program that also focused on infection prevention. In between a few of the meetings, we would have one-on-one touch base calls with the facilities to make sure that they understood if they had any questions about what was presented, and at the end of each session they were assigned homework to do prior to the next session, so we wanted to make sure that they were clear on what they needed to do. We also were able to provide training and educational materials so that it would kind of be a turnkey, that they wouldn't have to recreate anything, because we know that they're not as skilled nursing facilities aren't as rich in resources, educational, et cetera, as hospitals are. So we wanted to help make it easier for them. And then we also defined some process and outcome measures that we evaluated. Each facility had defined roles and responsibilities. They needed to identify a team at their facility that would do this work, and we recommended that it needed to include the medical director, the director of nursing, and their infection prevention nurse. The team together would work through the action plan. They were expected to implement a routine screening process for sepsis and process to manage sepsis early, as well as educate the staff on that screening and management process. And then we reviewed 3 common infections that can occur in an extended care facility: pneumonia, UTI and Claudy, and CLABSI, and they were expected to assess their current practices, comparing it to the best evidence-based practices, identify where there might be a gap, and put in an intervention to improve. And then ongoing. They're expected to submit process data on how well they're screening. Are they screening as appropriate, and are they screening correctly? So our first focus was to educate on why sepsis, why now, and the definitions and the evidence-based management and the early screening process. And so we focused on that to save lives, we need to early identify, give early antibiotics, and early fluid resuscitation. So part of our onboarding for this collaborative was also to have the facilities complete an assessment that kind of asked some questions. Do you have IV antibiotics available in your facility? Are you able to give fluid in your facility? What's your process for drawing labs? What's your typical nurse-patient ratio on the day shift as well as on the night shift? Because a lot of what we are going to expect of them needed to have certain structural elements in their facility to be able to accomplish it. So this is the sample of the screening tool. If most of the facilities have worked to put this screening tool process into their electronic medical record, but this is the screening process allows the staff, so this is done upon admission, every shift and with a change in condition, and they're expected to look to see if the patient has this systemic inflammatory response syndrome. If they do have two of these, then move forward and do they have a known or suspected infection? And if they do, then move forward to look for organ dysfunction. And so this is the first section, looking for the SIRS, and that's the temperature, the heart rate, respiratory rate, or white blood count, or blood glucose in a non-diabetic. If they have two or more of those, then do I have a known or suspected infection? If the answer is yes, then they should place the resident on intake and output so they can monitor their urine output and get a lactic acid ordered, and then look for organ dysfunction. And so look respiratory, cardiovascular, renal, and central nervous system. And if there was organ dysfunction, then they screen positive for severe sepsis, and they need to call the and FR script for them to use so that see here, if you're familiar with SBAR, it's situation background assessment, and the most important piece is recommendation. And so they would then request for the doc to order blood cultures, a CBC, a lactate, antibiotics, and fluid if the patient was hypotensive. We also linked it to a common process in the skilled nursing facilities, the Interact tool, the stop and watch portion that the certified nursing assistants use. And so we also educated the CNAs that on what is sepsis and their role, that if they identify, if the stop and watch is triggered at all and they let the nurse know, then the nurse will screen for sepsis to see if the change that was identified on the stop and watch was because that patient was moving into sepsis. So this is the example of the action plan. You can see here it's focused on the first, get the team together, develop your screening tool and process. We had the tool for them. They just had to define their process, get your medical staff support, educate your staff. The initial education and ongoing, we expected them also to put this into their onboarding of new clinicians. How are you going to educate patients and families? We provided them with a number of tools that came from resources like Sepsis Alliance and CDC. And then discussed the process metrics and then the outcome metrics as well, admissions and out. And then, so the first two sections were focused on steps, then about 3 and for each section on an infection prevention area. The pneumonia first, then UTI and Claudia, and then CLABSI. So this is a typical agenda, and I'm going to show you in a few minutes that we have this toolkit all put together that anyone can choose to replicate. All the PowerPoints are there, all the resources, and links to educational videos as well. So a typical agenda included, I told you that we sent them away with homework to do between each session, and so we would start off each session with them reviewing the homework from the prior meeting, where they could identify issues and barriers, and discuss as a group with colleagues from other facilities and begin to network and brainstorm and solve problems together. And then we would discuss the next area of focus on the action plan and end with what do you need to do as homework prior to the next meeting. So, for example, the homework after the first meeting was to complete the first 3 steps on the action plan, to get your team together, and to understand the screening tool and define what your screening process would look like in your facility, and then to go out and practice screening on 10 patients using the tool. So you come back and say, does it not flow? You don't understand something. Because the expectation, again, is that they would put in a process to screen every patient and then every patient every shift for a minimum of 7 days. Or if someone was on antibiotics for the length of time they were on antibiotics. As I said, we created some tools and materials for education for the staff, and so we also expected them after that first meeting to come back with how do they think they want to educate the staff. You can use the tools that we provided today, or if you have something else. So that was what they needed to report on at the second meeting. After sepsis, the focus was on infection prevention, and this was, so each of the infections had an action plan, and this is the pneumonia one. And again, they're very similar. You just plug in the different infections. So at each of the sessions, we reviewed the evidence-based practices to prevent those things, and then they were sent away with trying to do a assessment of what their current practices were, looking at their policies, but then also looking at 5 patients to see if the best practices were being done on those patients. Where's the gap? And identify where there might be a gap in best practice and what current practice is, and put in a solution to close that gap and educate the staff on it. So we've done a number of sessions, and Rob was one of the main facilitators as we expanded this in partnership with MPRO beyond just the facilities that St. Joe's sends to. So the first 2 cohorts were done in 2016 and 2017, and those were the initial cohorts that I did. And then we moved on to the other health systems in southeastern Michigan all signed on to say, hey, it's important. And we have been working in southeastern Michigan to identify each health system, identifying preferred providers of care post-acute. And the expectations would be that because we're sending patients to you in the post-acute area, we have expectations on how that care should be, and you're an extension of us, so let's work together and standardize those care processes. And sepsis was one that was identified as important, and that became criteria for preferred provider status. So we held sessions in 2018, 2 sessions of spring and a fall. 78 facilities completed the training, lots of positive feedback. We've just completed the winter 2019 session, and 30 facilities have completed the training. So you can see almost 120 facilities. And actually, the 2016 and 2017 most of the 2016 wanted to take it again in 2017, so they're just probably a total of 18 facilities together between those two times. So over 100 facilities have been trained, so we're very excited, and the feedback has been very positive. I'm going to show you some data that's, again, beginning to trend positive. This is the toolkit. You will get these slides, and you click on that link, and it will take you to the toolkit. All the things that I've just reviewed are in the toolkit so that you don't have to recreate anything, and along with a list of resources. So we're very excited about that. And we've moved beyond just southeastern Michigan. The west side of Michigan is also doing it, and then this toolkit has been used in other states, Florida, Tennessee, and Pennsylvania, to, again, partner with the skilled nursing facilities. Data. So it's good to change processes, but what's the impact of those process changes? And so we have both process and outcome measures. The process measures are related to, are you screening when you should be screening? So upon admission and every shift times 7 days, or the whole time someone is on antibiotics. So that's the first measure. And then the second measure, are you screening accurately? So when the nurse is screening, are they doing it correctly? And so you can see on this slide, the first line is the sepsis screening compliance rate and how to do it, what the numerator and denominator is. We've provided each of the facilities. Originally, they were provided with they're still provided with an Excel spreadsheet that has the formulas in it and has each of the months. Our expectation is that when they initially start, that they should audit a certain percentage of their admissions each week until they reach a compliance of greater than 90%, and then they can move to monthly auditing, and that information is reported through an MPRO dashboard, so they send their completed Excel document into MPRO, and then it becomes part of the dashboard. The purpose of this process measure is to really help them drive their quality improvement work. You know, if they're not at 90%, why? Okay, what are the issues? If you're not screening accurately, is there additional education that needs to be had, et cetera? So here's one of the metrics. So this is percent of patients screened for sepsis using the recommended screening tool. So overall, this is from April of 18 to December of 18, where all facilities are together at 80% for screening appropriately, and this is a breakdown of, in the last 3 months, what percentage of the people that are submitting data and what level of compliance they have. So I told you from this previous slide that we're at 80% compliance with the screening, but you can see that a number of facilities, in October there were 26 that were at 100% compliance, and that's improved to 29 facilities in November and then 33 in December. So we're continuing to see improvement, and this then allows us to identify, we have a facility by facility compliance rate as well, and we can identify where someone might be struggling and reach out and assist them. So we're seeing good compliance in the majority of the facilities. And this is screening correctly, and it's about the same. It's at 82% compliance. And again, we can see that we're seeing, again, improvement in the percent of people that are 100%, as well as above 90%. So then we want to look at readmissions, and so this is looking at the first group in 2016 and comparing it to other facilities that were not part of the sepsis program. And so you can see there's a line in 2016 where this group completed the training, and you can see that their readmission rate, the facilities that were part of the St. Joe group in 2016 are the dark blue line, and you can see that the trend line is showing a decrease. In 2017, everybody increased, but we can look at that group and we see that downward trend again in 2018. If we look at the 2017 group and compare it, we see less of a decrease in 2016 because they didn't start till 2017. So you see the line where they completed it in 2017, and you can see a significant decrease. They went from 5.8% down to 3.3%. And so this is looking at any patient coming to your facility, regardless of what their index admission was for, that their readmission is for sepsis. And we just have some early data. Again, this is our spring 2018 group. And because we're looking at readmissions and we're using claims data, there's a lag in the data reporting. So we have one dot since the completion of their training, and it showed a decrease, but one dot does not a trend make. So then we also, this is looking at the other pieces. So those first two data points, data I've showed you so far were in the first two cohorts, the 2016 and 2017, and then the last slide was the 2018. Now, as we've expanded, this includes the 2018, 2017, and 2016 facilities. So the blue are people that have been in the sepsis program, and the orange is no training. And so you can see that we are beginning to see a downward trend in this population as well. Then we also looked at mortality, and so deaths within 30 days or 90 days of discharge from index hospital stay with a diagnosis of sepsis. So this is looking at, my index was sepsis, and I went to a skilled nursing facility, and then what's my 30 and 90-day mortality. From the original cohort from 2017, you can see, so they completed it at the end of 2017, and it's the purple line, and you can see there's a trend down in mortality, as well as the 90 days. So that first one was, this was a 30-day, and then 90-day mortality. The purple you can see is the cohort, and there's this pretty deep trend line down. We've extended this program also. So we're very happy with the results, and anecdotally, as we talk to staff and as we go out to facilities that have had this program in place, the nurses are talking different. They are talking about early recognition of sepsis, and they're talking about the patients that they were able to get care for sooner and get to the hospital if they needed it. The physicians, when they receive a call, they're hearing this patient screen positive for severe sepsis versus I have someone with altered mental status and that's it. So the physicians then are feeling more comfortable treating that patient in the skilled nursing facility with antibiotics and even fluids and trying to prevent a transfer. We've extended this also now to home care. Again, the same concept. Let's work collaboratively with home care agencies. We've piloted it now with 6 agencies in the southeastern Michigan area, and it's a very similar design program, evidence-based practices and education. We utilize the performance improvement methodology with assessing your current state and then implementing it, and then based on gaps, and then measuring your performance, both at process metrics and outcome metrics. So again, they're expected to put in place sepsis screening and management, and attend the learning sessions. This was a 4-month program. The sessions were an hour and a half instead of an hour, and the first 3 sessions were in person, and the final session was virtual. And there was a coaching call between session 1 and 2. This is the screening tool we put in place. Looks a little similar to the skilled nursing facility one. This has as you're looking at identifying someone with severe sepsis or sepsis or severe sepsis in the home, because they're not in a facility, you're going to end up sending the patients to the ER versus being able to treat them totally in their home. What the screening tool does is, if I have an infection in 2 or more SIRS, but I don't have organ dysfunction, the clinician is asked to call their primary care physician and get some labs ordered and get the patient in for a visit. So in attempts to have them be seen in an outpatient versus having to go to the ER. But if they are screening positive for severe sepsis, they need to go to emergency. So where do we need to go next? We need to go to physician offices and community. So there needs to be bulletin boards like in Stroke Awareness Month, which is this month, where you see, the many acronyms on act fast and get into the hospital if you have these signs and symptoms, and we need to go there with sepsis. So I'd like to turn it over to my colleague, Rob, and I'm going to pass you the ball, Rob.
All right. Well, thank you very much, Pat. I do want to just really reiterate something before the ball gets passed to me, and I can control that. But that's really about collaboration for any of this work to be successful. And when I'm talking about collaboration, it's not only collaboration between health systems and their post-acute care providers, that being SNFs or home health care agencies when it comes to sepsis, but it's also collaboration across your geographical region. We've partnered with multiple health systems, St. Joe's included, where Pat works, and multiple other health systems in the area, which has really made things, made everyone really on the same page and really made things very successful. So that collaboration is just very important. So I'm going to talk about another project that we were able to do through that collaboration. I'm just going to get to my slides. And that's really around the SNF to ED handoff process. So where did all of this started? We really started seeing some climbing readmission rates from the SNF. And inside Henry Ford Health System, what we did is we reviewed some charts with some of our very high-functioning SNFs, and we saw some of their residents where they expected them to go to the ED, have a simple test done. They're actually being overtreated and being readmitted. So we met with some of our frontline emergency department staff and really found out that these residents were coming to the ED with no documentation, no handoff, and when they did have documentation, it was very inconsistent on what the expectations were for the ED. So we talked to the SNFs and we were like, hey, what are you guys doing? Most of the SNFs said we're sending paperwork. It varied in what that looked like and what it contained, but where was it going? If it wasn't making it to the ED staff, where was it heading? I talked to a lot of our EMS and transporting companies and found out there's a major variety around their regulations, around their documentation. Each medical control authority varies in what they cannot do and when they have to complete that. And even some EMS companies admitted that they were actually hoarding their paperwork to complete their documentation at the end of their shift. So I realized, and Henry Ford realized, that this wasn't a problem, and up to our hospitals and realized this really isn't an isolated problem. So just as we banded together to focus on sepsis, we decided to take a collaborative approach to this as well. So where did we start? I started with the emergency department providers and really talked with them on what they wanted to see for these patients coming into the ED, and they wanted 4 key areas. Resident information, their medical history, the reason for transfer, their baseline functional status, and then direct numbers to contact providers in the SNF to answer questions. They really wanted a lot of white space for narratives over checkboxes. But it really wasn't as simple as those 4 things. There's tons of detailed SNF regulations related to what needs to be sent at transfers and discharges. And this is what it looks like here. I'm not going to go through it section by section, but we had multiple calls and multiple meetings with SNF leaders to make sure the document met all of their needs. And this is really what the document looks like at the end of the day, and it captures those 4 major categories that the ED providers wanted to see. That resident history, the medical history, their usual functional status, and really direct contact numbers. And as you can see, this form does have a lot of white space, and it's designed for that on purpose. So we really standardized the form, but we realized not one form was going to meet all the needs of both. So we really needed to develop 2 packets, one packet designed to go to ED and one packet designed to go to EMS staff for them to complete their documentation. And that led us to the creation of the SNF to ED checklist. And this is really editable for the individual SNFs to make sure they're sending those additional documents that meet those regulatory requirements, things like medication list, labs, progress notes, and different things like that. We centralized a website just like we did for the Sepsis program, and all of this information can be found on the SNF, the ED handoff website there. There we have fillable PDFs. You can download the files in multiple different ways. And this went live really at the beginning of March of this year. And from March to now, the page has had over 500 views with 438 unique people viewing it. And we're currently working on integrating Point Care for SNFs that use Point Care. And we actually had one local SNF corporation was able to successfully build a form and Point Care on their own. And really this was reviewed and approved by the Michigan College of Emergency Physicians, so it was reviewed by the state level and got their stamp of approval. And then this is where that collaboration comes. So not only an expectation for the SNF partnered with Henry Ford Health System, but also the 8 Southeast health systems that participate through our regional collaborative. So that's all I really had for today. I'm going to leave us 10 minutes for questions. So I'll hand it back over to the webinar coordinator.
Thank you so much, Pat and Rob, for this great information and for all the hard work that you've done. We now have time for questions or comments for our speakers. Operator, will you please remind our participants how to get in the queue for questions or comments?
Absolutely. Ladies and gentlemen, at this time, if you have any questions, please dial *1 on your telephone keypad. Again, if you have any questions, please dial *1 on your telephone keypad.
So there was a question in the chat box about does the checklist and protocol address timely results of lab work versus timely collection? And I think that that is been one of the struggles as we continue to we're in this together with the hospitals, we're in this together with the skilled nursing facilities, and so we continue to meet just in general in collaboration. about, okay, what are your barriers? How is it going? This has continued to bubble up to the top, and it's gotten worse related to timely reporting of the lab results. And so we're going to work to try and meet with some of the major lab vendors and see if there's any way we can get better turnaround, because we're finding that the clinicians at the skilled nursing facilities, the physicians, the providers are saying, if I'm not going to get my lab back for hours, I'm going to send them to the hospital because I know I can get it back sooner, and then I can see what's going on. And so we understand that, and again, working collaboratively, we're going to work to try and resolve that.
Pat, and just to add another comment to that, one of the things around sepsis is lactate. And the point-of-care lactate machines are really just come down in cost. So if you feel this is really a problem, at SNF or some of the SNFs you work with, that's other intervention you can take.
Yeah, they tried that initially, and the ones that were available then were the one that people were using, and the ambulance company was using, off the mic or something. So, yeah, I think that, but I think it's just beyond the lactate. I think it's TBC and some of the other labs as well. So, thank you, Rob. I think those are good options.
And at this time, we do have a question from Janelle Shearer with Stratus Health. Janelle, your line is open.
Hi. Thanks so much, Pat and Rob, for your presentation. I just really loved it, all of it. And thank you for developing the toolkit and sharing with us, or sharing the toolkit with us all. And so I know that's on the Lake Superior Quality Innovation Network website. But my question to you is, can any organization, like a nursing home, just take the toolkit and do the project? And I'm particularly wondering about, do you have embedded in their education about what sepsis is, some of that basic information?
Yes. So, put education.
Okay.
Yeah.
Great. Thank you. And I just really appreciate your passion for this and sharing the story about your family. That was, it helps us understand why you are so passionate about it. Thank you.
Yeah, and that was in a year. But I'm glad I was, because they got the right. But thank you.
Yeah.
At this time, there are no other questions in queue. But just as a reminder, if you do have a question, star 1 on your cell phone keypad.
Hi, Pat and Rob. So these are some big projects, the SNF to ED project or form, and then this whole care continuum sepsis project. So can you speak to some of the obstacles or best practices that you used or overcame to engage leadership within the hospital or even with some of the nursing homes?
So, Rob, do you want to start off?
Yeah, sure. I think what I always leverage any sort of these big projects is always about data. I find leadership, no matter if it's in the SNF or in the health system, they like to see data. So, if anybody's looking to institute something like this, is start looking at your data. Identify gaps and opportunities that you have and really pursue those. And talking about the sepsis program in particular, Pat and I had, I think, I'm not going to call them competing programs, but programs going on at the same time that we're trying to accomplish the same goals. And I think it's always keeping the patient and that quality care always in the center of your mind. And bringing it that patient level as you try to drive these QI projects and realize that you're saving lives and improving care. Pat, I don't know if you have any thoughts to add on.
No, I think you're right. As both Rob and I shared, the impetus for doing both of these initiatives was based on data we found, and getting the executives to support that is possible by having the data. One of the things that I didn't emphasize were some of the key things that why we think the Sepsis Collaborative was successful, and it was really about engaging the executive at the skilled nursing facility and getting their support, and then the face-to-face learning sessions with having them go apply concepts that they learned right away and come back and say how they were going. So having those face-to-face was important, and then the ability to touch base in between sessions with the facilitator to answer any questions, so you didn't have a loss of a month because you weren't understanding what you were supposed to do. And so I think that, and then we listened as we rolled this out, as we got their feedback. Again, this is a partnership, and how can we help each other?
I think that's a big point as well is using basic, QIO strategies. We share today we summarize a lot of successes, but there's a ton of failures behind the scenes in both of these projects that aren't represented today. So that's the other thing that comes down is even though you get support and try something, it may not work, but it's about going back to the table and trying something else.
Yep. And that one of the failures right off the bat, and why this program, the inception of this program, was I just tried to go out for my facility to go out to the different skilled nursing facilities and do a one-time education event, and I would come back 6 months later and I'd be doing another one-time education event. So we said, that's not going to work. We have to embed and change practice, and how do we do that? And how do we help the facilities be successful and provide them with the tools using a performance improvement, evidence-based practice change framework?
Thank you. Operator, are there any last calls for questions or comments?
No, ma'am. There are no questions. Thank you.
All right. Well, thank you so much, Pat and Rob. I do call you the dynamic. We're so happy and thankful to have you speaking with us today. So this concludes this educational session. Thank you once again for speaking to us about your innovative strategies. The final webinar in the Success Story series is called Achieve Community Goals through Partnering with Aging and Disability Resource Center, which will take place Tuesday, June 26th. Before you close out today, please complete the survey that will pop up. We have also put the link to it in the chat. We appreciate your feedback on today's session. Once you have completed that evaluation, you will receive a certificate of completion via email. Please make sure that everyone on your team that wants a certificate completes the evaluation. The session was recorded and will be available on the Lake Superior Clinic YouTube channel in about 2 weeks. Thank you all for participating and have a great afternoon.
Thanks, everyone.